This is a good morning session, and I wanted to interject because we've done a PTAB live, but I need to basically, get the patient out of the room so that we get the next case in for the afternoon session. So this is a 74-year-old male who basically came in with severe claudication bordering on rest pain, actually. He's got bilateral saphenous vein ablations, peripheral arterial disease, severe symptomatic PAD with borderline sort of rest pain. Go to the next one. So we did a CT on him, and I think CT, when you do PTABs, are extremely important because it will tell you exactly the calcification, where the vein comes off, where the artery comes off, and you can see on the right, we really couldn't measure his ABI. Next one. So if you play that CAT scan quick, you'll see the CT is really nice because it'll show you whether there's dense calcium, where the vein is, where it reconstitutes, and sometimes the reason I'm presenting this is, we had a challenge, which is pretty nice to do, and I think Dr. Golzar touched upon this. As you can see, the distal SFA popliteal reconstitutes P1 and P2 segments, so the whole artery is completely occluded. So we went up and over today and did an angiogram, and you can focus on the TV camera. There it is. You can see the iliac bifurcation is extremely important when you do these cases, especially if you go up and over. The second thing is he had a flush occlusion. He had a flush occlusion, so you don't even see the takeoff of the SFA. And we struggled quite a bit because of the acute aortoiliac bifurcation to try to poke into that nipple. And after a while, I just gave up. So what we then did was we basically punctured the SFA and went retrograde. The blinded occluded SFA was punctured, and we went retrograde and opened the SFA and snared the wire up and over. And so that's a trick when you have flush occlusions, is you can puncture the occluded SFA in the thigh based on the calcium or even on ultrasound, and you can get back into this flush occlusion. And that's how you enter into this flush occlusion. We snared the wire from the top. We did the big fat T with a reverse 4 for the proximal puncture. And then, of course, we got a PT puncture. And then we went in and we basically repunctured here, as you can see. So the orientation here is a big fat 4 with a regular 4. So we repunctured and then exchanged, ballooned very aggressively the proximal and the distal reentry sites. Extremely important. So that's where we re-enter right at the level of the P2 segment. And finally, we finished this entire case by lining with them with the Taurus stents. So the takeaways, as you can see here, you can see it has to be really pristine. Sometimes you get sluggish flow, and I think the audience or even the people in the audience who do PTABs will realize that the sluggish flow is because there's a complete collapse of all of those collaterals. And then as you go further on, it opens up pretty nicely. And then we can give nitroglycerin, and then basically we did a runoff all the way down to the foot, and he has a very single posterior tibial. That's a vein puncture being taken off. Single posterior tibial. So yes, you can debate this all over again, because when I punctured the SFA, I could probably open the native SFA too. But again, opening a 40, 50 centimeter long SFA, occluded SFA pop, sometimes the patencies are not very good. You may go subintimal and it's even worse. But I think PTAB is an excellent example for these long segment SFA popliteal occlusions. You can do them through stents. You can do them for flush occlusions. And this guy had an attempted endovascular opening of his long segment SFA occlusion, and this failed, and then he came here. Because of lack of vein, otherwise he may be a very good candidate for a bypass. He's got good inflow. He had a good, nice popliteal below the knee and a single PT going down. And so I think that was one option. But again, we weighed the risks and the benefits, and he opted for this, and I think we'll follow him very closely. Post-op, I put these patients on 2.5 of Xarelto and then also Plavix. So thank you for a very nice session, and hopefully you can go and enjoy your lunch, and we'll come back to you soon. Thank you.